All right, week 7, seizures and mental illness. So with a seizure disorder, a lot of times patients can have an aura or prodrome, which is just like a sense of impending seizure, similar to what we had with, what was that? I want to say HIV or something. There was something where we had a prodrome, which was a sense of, or a sign of an impending, more significant illness of some kind. So that's just what a prodrome is. And aura also applies to, for example, migraines, where um, people can have some sort of like a visual disturbance that can indicate the oncoming of a migraine. So when we have epilepsy, epilepsy disorder or seizure disorder, epilepsy just means they have a condition of having recurrent seizures. And then status epilepticus is a very serious, very significant issue. In that they have a continual series of seizures. I don't think there's actually a definitive how long they have to have it for, but it's extended. So it's not just a seizure and then they quit. And a seizure oftentimes will last maybe about a minute or a couple minutes. But then status epilepticus is going to be where they have recurrent, it's back-to-back seizures. There's no real recovery time between the episodes. And this is very life-threatening. And the status indicates that it is continuous, similar to status asthmaticus. So when we do have a seizure disorder, that means that we have some sort of an excessive excitability of neurons in the CNS, and it ranges in how significant the impact is to someone's consciousness. So we may have periods where they are unconscious and they have convulsions, and the disorder itself, because it's impacting the brain or indicates that there is something in the brain that is misfiring, they may have learning disorders, memory issues, and mood issues as well. For a seizure to generate, generally we have some sort of a hyperexcitable area of the brain called a focus. And the seizures will start from that focus and either stay there or spread out. And that focus can have multiple etiologies. It can come from infection, head trauma, hypoxia at birth, stroke, cancer. So people who have had like a stroke can then, because there's damage to the brain, they may then have a seizure disorder because of the stroke. Cancer, idiopathic, and for a lot of people, they actually have it as a congenital or a genetic issue that comes shortly after birth. When you have the susceptibility for a seizure, and you have that seizure disorder, they can then be triggered by different things, like flashing lights is a very big risk factor. And then for kids, especially, fever is a major concern because a fever just gets the brain's wiring to act all sorts of funky. And then loud noises are also something that can be a trigger. And so we can split seizures up into generalized or partial. Where's partial? Down there, partial. When it's generalized, it'll start in a focus area. So let's say, it starts like right there. And then it'll spread out to affect the entire brain during the seizure. It'll involve the thalamus, the reticular activation system, and the person will have some sort of a loss of consciousness. Loss of consciousness does not mean that they are on the ground unconscious, though. It means that they are not going to have awareness of what's going on at that time. So they could look as if they are fully with it. They do not have any, like not actually having a seizure, or they may just be acting weird. But then you try to have them recall any information, anything that you said during that time when they were having that seizure, and they will not be able to recall it. So a common one for a generalized seizure, this used to be called the petit mal seizure, and now it's called an absence seizure. Basically, it means absence of attention. So the child is going to be sitting there, for example, in a school setting at their table, and maybe they're going to look to their teacher like they are staring off into space, not paying attention to what the teacher's saying, and the teacher thinks they're daydreaming. And if they were to go about trying to ask the student, what did I just say? If the student has recovered from the absence seizure by the time the teacher asks that, they won't be able to actually remember anything. And then, so for typically, the absence seizure will not have any kind of a physical, muscular response. It is simply a matter of basically not moving, staring, brain's taken over, but not really any muscular involvement. With the atypical absence, this is where we're going to have the absence seizure plus some sort of a muscular involvement, so myoclonic jerks or automatisms, which is going to involve parts of the face making unconscious, involuntary movements, and then also still having the staring spells. Myoclonic is going to be where we have a series of jerks, so not like a full-blown tonic-clonic seizure where the entire body is taken over, but certain parts of the body may rhythmically or arrhythmically jerk around and contract. So, like, for example, the arm or maybe the neck. And then we have the atonic or drop attack seizure. And you can think of this as being that the atonic is going to be like the atomic bomb, in that we drop the atomic bomb and there it is. The atonic drops the person and they fall down. Atonic-clonic used to be known as a grand mal seizure, and this is going to be the classic kind of seizure like you can see in this picture here, where the person's going to be going through tonic stages where everything is kind of extending, and then clonic stages where they are jerking many muscles. It goes back and forth, and it's a very distinct look. They may not be breathing much. They're going to be flexing every single muscle in their body. And it's actually very frightening the first time you see it. So that's general seizures. General seizures affect the entire brain, and they will result in an inability to process or use any data at the time. So they'll be unconscious, but that doesn't mean that they fall down or that they're on the ground unconscious. For a partial, this is going to affect only one side of the brain, but it can extend beyond that to involve the entire brain. So a simple partial, so a partial can be split up into either a simple or a complex. And then we have this other random one of where it's partial, then it generates into a generalized seizure to involve the entire brain. So with a simple, we have no change in consciousness. We can have motor, sensory, autonomic symptoms that occur. So we can have someone with automatisms. We can have someone who has some myoclonic jerks, but it's not a full-blown generalized myoclonic seizure. They may smell something strange or hear something strange, have some twitching of the face, a lot of things over here that we can see, and then visual stuff as well. So things that they can recall, things that they can see, hear, smell, taste, whatever, but there's no change in consciousness. A complex partial is going to be all the above, plus a change in consciousness. So they may, for some part of it, become unconscious, and then for another part, they may still be conscious. And then again, the partial with a secondary generalization is going to be where we have the simple that then advances to a generalized. So we may end up having it could be a full-blown tonic-clonic, it could be a regular myoclonic. It doesn't have any specific type of progression to what a partial will develop into. So diagnosing someone with a seizure disorder, we're going to do an electroencephalogram, which is what we see up here, to assess the logical patterns, figure out where is this focus, Can we tell based on where it is, what it may have come from, what we can do about it? We're going to do laboratory studies to identify any possible etiologies. So if someone's... So cats are great, except for when they toss your shit everywhere and knock down your cups of water. Okay. Where was I? So laboratory studies. Come on, be up there. Laboratory studies, we're going to be doing those to determine, is there an infection, for example, that may lead to the development of seizures, which is reversible potentially with treating the seizure, treating the infection. Same thing goes for doing lumbar punctures. So if a person has maybe meningitis, a pneumococcal or meningococcal infection that leads to seizures, treating that might result in being able to reverse the seizures. And then doing CT and MRIs will help to determine, is there something about the development of the brain that has led to them developing seizures. So during the seizure, we're going to want to maintain the airway. Let's back up a bit. So when we see someone who's developed a seizure, they're having an active tonic-clonic seizure especially. The other ones aren't as critical towards emergency care. So a grand mal tonic-clonic seizure, we're going to want to put them into whatever position we can that is best for them. If we can, we would want to roll them onto their side to try to prevent them from aspirating any drool or oral secretions, and to help get their tongue out of the way from their airway so that they can breathe. Do not ever put your fingers into their mouth or anything else into their mouth, because on the minor scale, you can chip teeth if you put something else into their mouth, and you could be liable for that. And two, if you put your fingers in there on the other end of the spectrum, you might lose your fingers. Their jaws will be so tightly clenched, and there will not be a pain mechanism to indicate to them that their jaw is undergoing a lot of stress. You may just straight up lose fingers. So they're on their side. You're protecting their head, making sure that it's not hitting the ground. It's not hitting any other items or structures. If they're on the ground, I'm imagining this as out in the public. They will be on the ground. You're protecting their head, clearing away from them everything else that they could hit any part of their body on. And then you're trying to hold and stabilize their head as easily as you can. You don't want to restrict the head movement, but you just don't want their head to be hitting the ground or anything else around them. But you also don't want to hold their head so still that you end up giving them some sort of like a cervical spine herniation or fracture or anything, which can happen. You let them have their seizure, you call 911, or if you're in the hospital, you're activating your emergency system, or whatever the protocols are. And if they're going on long enough, then you can maybe consider putting on a BVM with a face mask and starting to ventilate for them or help them, assist them with their ventilations. And then you're wanting to watch the entire episode so that you can document what's going on. And sort of like, is this a status epilepticus or is this a regular tonic-clonic seizure with an actual recovery period afterwards? You'll learn more about that as you go into acute care. Otherwise, we also want to educate them on avoiding triggers. So if people have problems with lights, tell them don't go somewhere that has strobe lights. Maybe you can't go to rock concerts that utilize some strobe lights, or if you do, then you need to cover your eyes when that happens. Or if there are certain sounds that you have that trigger you, avoid them. We want to talk to them about taking anticonvulsant medications to help manage their seizures, but explain to them that they are not curative. They are for managing them and trying to prevent them. If they have gone about 2 years without having seizures, then we can try to taper them off gradually so that we can see if they can exist without having to take medications. We always like the idea of not giving them medications that they don't need. There's also the potential that they can use a ketogenic diet which is one of those high-fat, low-carb diets, which is a bit of a trend at this point right now. But for whatever reason, it seems to be that when the brain uses the ketones for energy rather than glucose, that helps to sort of stabilize it and prevent it from going into a seizure disorder. Treatment also for seizure disorders under the umbrella of surgery, we can try to actually remove the seizure foci depending on how big it is, where it is, what kind of an impact it'll make on the brain's function if we remove it. We can do neurostimulation, which is what these guys are. And I think that's the vagal nerve. These guys here. And they actually stimulate that area of the brain to prevent it from going into a seizure. And then on this side, this little doohickey here is attached to the vagal nerve and sending regular mild impulses to the vagal nerve, which the vagal nerve is associated with parasympathetic nervous system activation. And it's the opposite of what the brain needs to engage in seizure activity. The sympathetic nervous system will more likely activate a seizure than the PSNS. Activating it will help to just sort of manage the activity of the brain. The overall goals for therapy is that we reduce seizures to a level that's normal so that they can have as normal life as possible. I guess normal would be the absence of seizures. We want to have an absence of seizures, but sometimes we can't have perfect normal absence of seizures, so get it as low as we can. And then balance seizure control with side effects, since as Farm showed, we have a lot of side effects that can come from anticonvulsants. All right, cerebral palsy. So cerebral palsy is really a umbrella term for a diverse group of syndromes that will start to appear during childhood, and it itself is a chronic muscle tone and coordination disorder. So there is some sort of a permanent but non-progressive damage that occurs to neurons, to nerve areas, during childhood. And the damage occurs oftentimes to upper motor neurons that control the voluntary and involuntary muscle movement. So we can have several different etiologies. Prenatal infection is common. Mechanical trauma to the head, the child's head, before, during, or after birth is very common, as is a temporary decrease in oxygen supply to the brain. Those are going to be the two big ones that that encourage the development of cerebral palsy. But also exposure to toxins and prenatal infection are possible etiologies. Manifestations are going to include spasticity, which actually has a very specific, they don't have it, definition. It involves the regular, you think it's like jerking, but it's not as much jerking as it is regular contraction. So as you might be able to see in certain pictures of kids with cerebral palsy, they have certain joints that really won't loosen up, and it'll be hard to really utilize those joints because they're just kind of locked in one position. Ataxia, which is difficulty in coordination, and then dyskinesia, which is difficulty in movement. They can have just one of these, they could have all three, or any combination of those. And the treatment for this really, it depends on how far throughout the brain the cerebral palsy has extended. We can give them muscle relaxants, anticonvulsants, maybe give them surgery, and then just some more basic, like how do we stabilize the joints and provide them the ability to have as normal movement as possible using casts, braces, or traction. We can also give them Botox for those joints that are really stiff and they're always contracting and are just really painful because they're always at that contracture. And the Botox will help with the pain and to kind of loosen up some of those always contracting joints. Cerebral palsy, though, will present very dramatically from person to person. Some people will simply have minor ataxia, or they'll be just a little bit having some spasticity, but otherwise look normal, while others are going to be bound to potentially a wheelchair because of just how significantly they're affected by cerebral palsy. The impacts on the brain are not always related to how severe the physical impacts are. A lot of people think that cerebral palsy means that they are going to have severe cognitive impacts because of cerebral palsy, but some people may have absolutely no impact whatsoever to their cognitive abilities, whereas others may have a very severe cognitive impact. So it really goes from one end of the spectrum to the other for both physical impact as well as the cognitive impact individually. So people can have intellectual disabilities, psychiatric conditions, seizures, difficulty hearing and seeing, muscle tone issues, urinary incontinence is a common issue. Of course, difficulty walking is a common problem. If it gets bad, they can have swallowing disorders, difficulty eating, a lot of really significantly impacting symptoms, but it really depends on how they range and how the individual is affected. Okay, so now we're going to neuropsychologic pathophysiology, schizophrenia. So schizophrenia is where a person has, or it comes from the Latin, Greek, I don't know. The base of it is split mind. So they have a split or separation so that they don't really see the world the way that the rest of us, the way that those who don't have schizophrenia see the world. So they have thought, behaviors, or feelings that are disordered or disorganized and disconnected from reality, which is really the definition of psychosis. So when a person is in psychosis, they're completely dissociated from reality. When you talk to someone, which you guys hopefully will be given this opportunity to during Cron 2 at the Oregon State Hospital, you'll meet a lot of people who have schizophrenia. It's one of the most common diagnoses at Oregon State Hospital. And when you talk to them, you find that they're not able to track the conversation necessarily sometimes. It depends on how well medicated they are and how severe their schizophrenia is. But they can have significant struggles with understanding the connections between certain thoughts and reality, consequences and actions, and understanding what you're trying to say as literally the words you're using. So when we have schizophrenia, they found that it actually impacts the structure of the brain. So it's not just like a chemical imbalance. There's actually like a structural issue at play here as well. For women, they generally start at 25 to 35 years old, and for men, onsets are normally 15 to 25. For whatever reason, I'm not sure why, women have better outcomes. When it comes to the actual chemicals that are involved, as a result of the physiologic or anatomic differences that occur between a schizophrenic brain and a healthy brain, there is too much D2 activity in someone who has schizophrenia, and we also have too little D1 activity. So there's too much D2, too little D1. We've also known that, or seen that glutamate transmission is definitely, you know what, I don't even, okay, so this is the only, I don't know what this has to do with this. I don't think we ever even going into that much in the first place. This is important from the perspective that we have, from a result of the medications, we have extra pyramidal symptoms, and that comes from the fact that the pyramidal cells are, as we can see here, misarranged. They're kind of all wonky compared to what it's supposed to be. And I don't exactly know what pyramidal cells are in the first place necessarily. But we know that pyramidal cells are part of what influence those EPS, extrapyramidal symptoms, that come from having too much, or that block too much dopamine in the brain with anti-schizophrenic medications. So, I mean, to recap, because that was confusing, too much D2, too little D1, funky pyramidal cells, call it good. And it also occurs in the prefrontal and temporal regions of the brain. Okay, so there are some genetic components that are risk factors. If both parents have it, then they have a much higher risk of developing schizophrenia. And this is a big one for both the test and for the NCLEX and for general education for patients. If the mother develops the flu, especially during the second trimester, that has been a risk factor during gestation of developing schizophrenia, as well as if there are any other kind of birth complications, there's a potential that the child will develop schizophrenia. So encourage highly your patients to, if they're eligible for it, of getting their flu vaccination when they're pregnant. So schizophrenia's manifestations are developed into positive symptoms and negative symptoms. And we don't mean that to be as a, like, these are good ones, these are bad ones. We mean from the perspective of like think of like a number line, with baseline 0 being what we would expect for a normal, healthy person who does not have schizophrenia. So positive symptoms are going to be where we have extra symptoms that we shouldn't have. So delusions. We shouldn't be having delusions. We shouldn't be having hallucinations. We shouldn't be having disorganized speech and disorganized behavior. Things that are extra. Things that a healthy person shouldn't have that are on top of what we already have. And these come from reality distortion and disorganization and are a result of extra D2 receptor activity. Whereas negative symptoms are going to be associated with too little D1 receptor activity and reflect on that like number line a decrease or a loss of normal functions. So, for example, they may have, normally, a person's going to be socially positive, they're going to be capable of interacting with others and conversing with them, whereas with someone with schizophrenia, they may be socially withdrawn and isolated. Their emotional affect may be dull or blunted, and they may have poverty of speech, which really just means that they aren't really able to communicate well and may even be selectively mute. And this all comes from too little D1, and like on that number line means that we have a reduction, a loss of activity that should be there. So when it comes to the cognitive impacts, a lot of these people have severe learning problems, problems with attention, with memory, with understanding abstract ideas, and with planning, with comprehending complex thoughts. Their learning abilities are very significantly impacted. And one of the things that you're going to see in Oregon State Hospital is that, especially those who are there for supposed or suspected criminal activity, because they are not able to aid in their own defense, they are sent to Oregon State Hospital to try to go under treatment, to try to stabilize them. And then they also go through treatment mall, which is a morning series of classes, and afternoon series of classes that help specifically for them, the ones who have done a crime of some form, with developing legal skills so that they can aid and assist in their own defense. But these legal skills are very, very superficial. They're very elementary because a lot of these people don't have the cognitive functions to really be able to grasp the subtle and complex nuances of legal defense or really a lot of different things that require higher cognitive functions. So nursing implications for someone with schizophrenia, we need to encourage case management. So we need to have someone overseeing their case because the world is not set up well for someone with schizophrenia. They have a lot of things going against them. There's not a lot of opportunities for social integration, especially for those who have come out of jail with schizophrenia, or those who can't necessarily stay at home with their parents. And so we need someone to sort of navigate the healthcare system to make sure that they can get access to all the help they need. We want to provide the best treatment for them in the least restrictive setting because the more restrictive of a setting we put them in, the worse their outcomes are going to end up being. We want to optimize their quality of life and their social function since that'll help to make them better as well. Cognitive and dialectical behavioral therapies are really effective for them. Social skills-based therapies are really important, as are providing some sort of vocational rehabilitation so they can maybe have a job, however basic it may be. And then family therapy, due to the severe impacts that schizophrenia can have on the relationships within the family unit. So bipolar disease or disorder is going to be a recurring set of symptoms that occur between depression and elation, potentially mania. If an episode of mania is significant enough to produce psychosis, which is that distortion, that separation, dissociation between reality, between them and reality, it may end up being mistaken for schizophrenia, which the treatment of that is not in line with what treatment is for bipolar disease or disorder. I keep saying disease. So we got to make sure that they are getting the right diagnosis for the right treatment. So it can be either inherited or acquired. There are some indications where having a parent or a sister or brother with it indicates you have a higher risk of it as well. And it can also be due to trauma in your childhood as well. And it comes with impaired emotional processing. And the neurotransmission deficits that they experience will lead to depression, whereas the neurotransmission excessiveness will lead to mania and or psychosis. So mania is going to be the hallmark symptom. This is really what differentiates bipolar disorder from just major depressive disorder or any other depressive-like syndrome. And mania is going to be where we have a persistently elevated or expansive, irritable mood. They're going to have a strong sense of grandiosity, a high sense of self-importance from anything they do and about anything they do. But in children, it may manifest a little bit differently in that they'll just simply be irritable and may be confused for having ADHD, which treating ADHD and treating bipolar disorder also are vastly different treatment modalities. They're going to report a decreased need for sleep. They're going to think that they can get by on 2 hours or no hours of sleep. They're going to have a significantly increased level of talkativeness. They're going to have flight of ideas, so they're going to have idea after idea after idea. You're not going to be able to keep track of them all because they're going so quickly. And they're going to be so highly distractible that they can't necessarily focus on anything. They're going to have an increased sense of goal-directed activity. So if we're talking about like bipolar type 2, where it's not the super high mania, it's like hypomania, they may actually be more socially or vocationally or academically active, may even be sexually more active, and for social, work, or school-related activities, they may actually be more productive. When it's true mania from bipolar type 1, generally they will only perceive the efforts here to be more productive, but in reality they're so distracted and so cognitively disoriented that they're not really being more productive. They're also going to have psychomotor agitation and have excessive involvement in high-risk and pleasurable activities, such as having, a super high buying spree or going and having sex with everybody who they know. So, as we said, there is bipolar type 1 and type 2, with type 1 being that they have full-blown mania as well as major depression. Bipolar type 2, it's not mania, it's hypomania, and also having major depression. So the difference here is that with mania, we have symptoms that persist for at least 7 days. And they're going to have either impaired functioning or full-blown psychosis. In contrast, hypomania is going to be less severe and shorter. Symptoms will persist, according to the textbook, it's not greater than or equal to 4 days, it is up to 4 days, but just remember the number 4 days for the test. There will not be psychosis, so they will not be fully and totally dissociated from reality. They're still going to be kind of with it. They will have an individual belief of increased productivity. In some, it may actually be that they are more productive, but they'll also be having that as a sudden onset. So they're going to be going normal, and then suddenly they have, wow, I have all this extra energy. I have all this ability to be productive. I don't need as much sleep, all that stuff. So that's really the difference between hypomania and mania. There's also a third definition, which we don't really go into much here, but you go deeper into during Cron 2, cyclomania, where a person is not really at major depression, they're not at mania, they don't meet the criteria for bipolar type 2, but they're not really just plain depressed either. It's not just a straight depression disorder. They also do have some cases where they are having episodes of hypomania. That would be where cyclothymia comes in. So here we have bipolar type 2, where it goes as high as hypomania, but we still also have the major depression. And then bipolar type 1 ranges all the way from major depression to full-blown mania. So the treatment, nursing implications, we want to rule out any potential that there are some other medical conditions or drug reactions that this person may be having. We want to put them on mood stabilizer drugs such as lithium. We want to provide some family-focused treatment because, similar to schizophrenia, bipolar disorder can make or have a significant impact on the family bonds, the relationships, because of just the fact that if someone's got bipolar disorder and you can't reason with them and they start to, it's just, you can imagine. We want to engage patients during their depressive cycles, not their manic cycles. During their manic cycles, they're not going to be responsive. They're going to think, oh, everything's wonderful, everything's great. During their depressive cycles, they're going to think, okay, something needs to change, this sucks. And then we want to also try to reduce relapses by educating the patients on identifying the early signs of relapse, promoting really good, regular, healthy sleep-wake cycles, and promote the continuation and the adherence of medications, because if they don't stay on medication, they're at a really high risk of going into another episode of mania. So in regards to mental illness, this sucks. Women are more affected with depression and anxiety disorders than men are. might have something to do with the patriarchy. Um, Gender factors that can influence this, their marital status. So for men, marital status is helpful because they have women who are able to influence and um, help keep men balanced. Men, of course, seem to make women's lives worse a lot of times because of the increased demands that women end up having, gender differences, gender roles, the expectations of women nowadays, especially, being that, hey, you not only need to now work because the family can't have enough of an income to meet their own needs by simply um, the guy working, but now you have to work also, but you also have the work at home to take care of with the kids and the household stuff when you return, while the dude goes on to whatever. Um, and then exposure to sexual abuse, assault, and physical violence. Thanks, guys. Um, can make an impact on women's risks for depression and anxiety disorders. Going into, I think it was Cron 2, or was it population? No, it's population. In population, we talk about chronic stress and the impact of constantly being a submissive and having having the chronic stress associated with um, basically not having equality and equity associated between two different individuals is associated with significant health impacts. And so a lot of that is why women may end up having higher levels of depression and anxiety than men. It's because men typically have the power within the society and culture, and women are taught to be submissive and subservient. Hopefully we're changing that. So we also have some biological impacts that can occur from changes in serotonin receptors or reproductive hormones, and differences within the hypothalamic pituitary, um, oh shoot, what's the last one? Adrenal axis. And then there are also differences in culture that occur with mental illness. Certain cultures are a lot more stigmatizing of mental illness, whereas others are not. Um, and knowing those can help towards reaching out to those cultures and knowing how to educate them and empower patients who have mental illness and their families towards being able to manage the disorder.